I've had a problem with one of my ankles since birth. It's been operated on, pinned, fused, bone graft, you name it. Nothing worked.
When Trina came to Team Rehabilitation, she said they tried everything. I asked her to let me try.
Beth researched my situation on her own time.
I found a treatment I thought might work.
She just worked with me and took the time that no one else took. Beth solved it.
Team Rehabilitation. Visit team-rehab.com.
Welcome. This is Dr. Kanapke's joint replacement class. My name is Joel. I'm Dr. Kanapke's physician assistant, and joining us today will be Dustin from Team Rehabilitation. During this class, we'll be outlining expectations, preparation, and milestones surrounding joint replacement surgery. We'll be talking both about hip replacement, total knee replacement, and partial knee replacement. There are very few differences between a hip replacement, a total knee replacement, or a partial knee replacement, but those differences, as we walk through this presentation, will be highlighted. So let's begin. To start, we talk about arthritis, and arthritis comes in many different forms. And as we see on these pictures, arthritis is ultimately erosion of the cartilage at the ends of our bones, whether it's a hip or a knee. And many times arthritis sort of looks like our roads around here, and that you have potholes of various different sizes. Arthritis comes in many different forms. The most common part is osteoarthritis. It affects most of us beginning at age usually 45, and is a result of either wear and tear through our normal day-to-day routine or hereditary. So parents, grandparents have had arthritis, and thus we're a little bit prone to that as well. Other types of arthritis are rheumatoid arthritis that more affects the outside or puts the joint in an environment that's inflammatory that leads to further degradation of the cartilage, just as we see here on the pictures. Traumatic arthritis, which is either as a result of a previous hip fracture or a result of previous surgery. We've had a hip fracture, or let's say a previous ACL injury or a meniscus surgery. Those can lead to the same mechanical changes within the joint that leads to wear and tear. Again, much of what is seen, on these slides. And so when we're talking about arthritis, X-rays are helpful, which we can see in some of these locations, in that there is some areas that are bone on bone in this location here, and also for a hip in this location here. But the X-rays are only a part of that picture. So it depends on where the arthritis is located at to determine how symptomatic it may be. And those symptoms drive many of our patients to look for various different types of treatment. Treatment of arthritis is either down one of two pathways. One pathway is buying time, and the other pathway is fixing it. When we talk about buying time or fixing it, the goal is pain relief and improvement of function. The first thing when we talk about buying time, we think about anti-inflammatories, modification of activity, and many times these things work well. When that's not effective, we typically seek other treatment. It usually results in visiting of a physician or an orthopedic surgeon. Those type of treatments to try to buy time are more effective in our knee patients. And those things are like injections, whether it be cortisone injections or gel or viscosupplementation. Both of these types of injections are meant to try to buy time, either done every 3 months or every 6 months. And the goal is to try to decrease pain and improvement of function. For our hip patients, injections, although can be effective, are usually very fleeting in their relief. And so typically for our hips, there are less options to try to buy time. So when we've tried anti-inflammatories, we've tried injections, we've modified our activity, then we start saying, well, if our world continues to be confined or restricted, where we feel like we would be doing more if it wasn't for this hip or knee pain. And the things that we're doing won't loosen those limitations or restrictions. And you still feel like I'd like to do more, or my decisions of what I choose to do versus what I choose not to do is not based on desire, but more based on what the knee or hip will allow you to do. And again, that sort of radius of activity starts to shrink. Then we're looking at more of the fix. Now, when we talk about fix, about surgery, and that typically is replacement surgery, whether it be a partial knee replacement, which is seen here, a total knee replacement, which is seen here, or a hip replacement here. Now, when we talk about joint replacement surgery, these things are meant to last for a very long time. They're meant to be durable. The goal of joint replacement surgery is a pain-free activity and ultimately getting you back to doing most things that you want to do. And we'll talk a little bit more about that. Sometimes prior to joint replacement surgery, some patients will say, well, can't you go in there and just clean it out through a scope? Well, a scope, although a surgical option, is extremely variable as far as its success rate. It's about 50-50 as far as improvement. And so in many cases, when arthritis is advanced, like we've seen in those previous pictures, a scope in which we just go in and clean things out can make the joint look different, but it doesn't get rid of the arthritis. And ultimately, in many cases, may either result in unchanged function or worsening of function. So the first thing we talk about is hip replacement. Hip replacement is, as we see on this picture, a socket that is inlaid into the pelvis itself, and then a stem that gets inserted into the femur, which is seen here. For a hip replacement, it is meant to last, over 20 years and allow you to do anything that you want to do. And so it's meant to walk, bike, golf, swim. You can lift. You can get back to activities such as gym workouts, but it's not meant for long distance running. You can run across the yard or run down a base path, and that's true whether it's a hip replacement, a partial knee replacement, or a full knee replacement. And again, with a hip replacement, what's fixated, the coatings on both the cup on that pelvis side and on the femur side is a grip glass material, and it acts a little like Velcro. So when it's inserted into the bone, it's a biological fixation, which allows the bone to grow into these surfaces. And so there is no glue that is used. This is a biological fixation that adheres to the metal itself. The bearing surface that's used in a total hip replacement is a ceramic ball and a plastic liner. That surface is modular. So that means that down the road, 20 years or more down the road, that we can change the ball or change the cup and restart this clock. And so the bearing surface is the key. The metal pieces, the stem that goes into the femur and the cup that goes into the liner have the potential to last for a very long time, and just the bearing surfaces can be exchanged. A knee replacement, whether it's a total knee replacement like we see here, or in a second, like a partial knee replacement, is a little bit different. And so for knee replacement, we still have metal, plastic, and metal, and it's still meant to be durable, lasting well over 20 years. And it allows you to do the things that you want to do, including things like kneeling. The difference is that the metal surface, both here and here, and we'll see this also in our partial knee replacements, are glued into place. And that glue it does adhere the metal to the bone. The plastic middle, which is seen here, is the bearing surface, just like on the hip replacement. And that's the piece that over the course of time will wear, much like how tires wear on a car. And just like a tire on a car, that plastic piece can be removed and reinserted in order, again, like the hips, to restart the clock. And so hip replacement, doesn't have that sort of porous ingrowth that the bone grows into the implant. It's cement that's used that adheres both the top cap and the bottom cap here to the bone. A partial knee replacement or unicompartmental knee is just like a full knee replacement, except you're not as extensive. Where we looked at the previous picture where the entire joint is replaced, in this picture, we are just replacing usually the inner side of the joint. The components are the same. It's a metal cap on the top, a metal tray on the bottom, and they're also fixated to the bone by glue. And that plastic middle, that is the bearing surface, that allows it, gives it its sort of life, or gives it its sort of durability. And that's something that down the road, 15, 20 years down the road, may need to be replaced. And so when we get to the point where we feel like our world is shrinking and we're unable through buying time to loosen that grip, joint replacement surgery is sort of that next step. And when we get to that point, the next step is sort of how do we go from I know or I'm thinking I'm ready for joint replacement to getting to the surgical date. And that's our first sort of topic of discussion, preparing for surgery. The first thing is getting clearance from your primary care. And that usually is sort of making sure that you're healthy enough to undergo surgery or getting you in the best physical condition. So in many cases, talking with your primary care, getting basic blood work like a CBC, kidney function, liver function, and blood glucose levels or hemoglobin A1C. If you do have other providers that are involved in your care, like a cardiologist, an endocrinologist, or a pulmonologist, you also want to let them know that you're having upcoming surgery so that they can change some things potentially within your treatment plan or improve things to make sure that you're in the best physical condition for an upcoming surgery. Once we get that clearance, which says that, yes, you're in the best physical shape to have this surgery, then we're sort of getting the ball rolling. One of the largest things that we tend to talk about is there are certain medications prior to surgery, which we outline here in this slide, that you will need to stop 10 to 14 days prior to surgery. The largest class of medications are your supplements. And so we're talking like omega-3 fatty acids, glucosamine chondroitin, fish oils, or a multivitamin. Now, as we talk about these different medications, and this is an umbrella statement for all of them, and that the reason why we have you stop them is that it has the potential to cause the blood to thin. And so thinning results in not only problems during the surgery as far as potential increased blood loss during the surgery, but more importantly is after the surgery can result in bruising as well as swelling after the surgery itself. And so stopping these medications, not only the 10 to 14 days prior to surgery, which is important, but also in many cases, stopping them for 3 weeks afterwards would be important. And so that's true for our first class, which is the supplements. The next large class of medications are your anti-inflammatories, those things like Motrin, Aleve, or even Mobic. Those things you'd want to stop ahead of time. Now, if you take things like Tramadol, Ultram, Norco, hydrocodone, oxycodone, those things you can take up to the time of surgery. The next more obvious class of medications are your blood thinners. So Plavix, aspirin, Coumadin, Pradaxa, Xarelto. As you can tell, there are a few of these type of blood thinners. All of them have different start and stop times. And so depending on who prescribes you that medication, so let's say your cardiologist prescribes you Xarelto, you'd want to talk to that provider to say, when do I stop those medications? Sometimes it can be a week ahead of time. Other times it just may be 24 hours prior to the surgery. Any blood thinner that you're taking prior to the surgery, you will resume that medication the following day. If you are not on a blood thinner prior to the surgery, we will place you on a blood thinner afterward, which we will discuss here in a minute. The last class of medications are what I would call rheumatological medications or disease-modifying agents, things like methotrexate, Plaquenil. Those things have an immune suppressant effect, And so we also want you to stop those that week ahead of time, and then also for 3 weeks afterwards. Now, you can take your normal blood pressure pill prior to surgery, cholesterol pill, diabetic medication. Those medications can be taken up to the time of the surgery. There may be some small exceptions to that rule. Anesthesia from, whether it be from Troy Beaumont or from the Orthopedic Surgical Institute, will contact you to sort of give you those small differences in between certain medications. As far as medications that you'd want to bring with you to the hospital or to the surgical center, those would be, one, you want to bring any blood pressure medication that you take with you in the pill bottle that it's dispensed in. The second one would be an inhaler. So if you albuterol, you would want to bring that medication in the inhaler that it comes with. Other than that, you can leave all other medications at home. The next thing that we do prior to surgery would be getting ready from a standpoint of some basic blood work that we have you get 2 weeks ahead of time. And that typically is a CBC along with a nasal swab test. The nasal swab test is a test that looks for Staph aureus, or in particular MRSA. And that test is where they swab the inside part of your nose for that bacteria. If that test is positive, we will notify you of a positive test. And in your packet of information that you get from our office, there is a prescription for Musiprin or Bactrim. That prescription can be filled at that time only if you're positive. That's a medication that gets swabbed on the inside part of your nose twice a day for 5 days. Now, it does not matter that you complete the entire course or complete the entire 5 days prior to your surgical day. In some cases, you may be notified just 1 or 2 days prior to the surgery. If that's the case, start with the medication at that time and then complete the entire 5 days, even if that's a few days after your surgery. It doesn't matter that it's completed ahead of the surgery. It just matters that it's completed, whether it be before or after the surgery itself. And that's meant to decrease the bacterial load on your body. In that same vein, we also recommend a special type of soap, which is called Hibiclens or chlorhexinate. This soap is also used to combat Staph aureus. And this soap is used 2 days prior to the surgery from your neck down, and then the day of surgery, just of the leg that you're having done. That soap is only meant to be used prior to the surgery. After surgery, you can use whatever soap you choose, body wash. The soap that's this Hibiclens or chlorhexinate can be very drying, and sometimes if used for too long can cause a small rash and irritation to the skin. And so it typically, you can pick up chlorhexinate or Hibiclens at any pharmacy, and it usually comes in a mint green bottle. It's a pink liquid soap, although today they also have different types of applications, whether it be moist towelettes or other things that can be used. And, from a standpoint of, definitely it meant to help decrease the viral load. The next thing that we talk about is sort of getting your home ready for surgery itself. And that means sort of preparing your house. First thing is sort of looking at the layout of your home, rearranging furniture, increasing the space in between sort of chairs or also hallways to make sure that you can get a walker through, removing loose rugs. And in the bathroom, you want to look at, do you need certain medical equipment, whether it be an elevated toilet seat, also a shower chair or a tub bench to help slide you in and out. Those things can be obtained either at a medical supply store, or you can contact our office and ask for the durable medical equipment department, and they'll be able to get those supplies for you prior to, whether it be in your bathroom or in your kitchen or even in your closet, you want to try to bring things that you use on a regular basis down from high areas or up from low areas to a more accessible spot. And so you want to get those things that you use frequently to an easy to grab place. So thinking about that in your bathroom and in your closet and even in the kitchen. So appliances that you may use on a regular basis, try to get them to easy accessible spots, and also a little bit of food prep ahead of time. So you have snacks and things that you could eat. Not that you won't be able to prepare a small meal, but that you probably won't really be thinking about that. So if you have some quick snacks that you can grab throughout the course of the day, for at least for the first few days, is always a good thing. You will be able to go up and down stairs after the surgery itself. And so if you have a bedroom that's upstairs, you will be able to go upstairs. You're not going to want to do that all that frequently, but it can be done. You would want to have a central command within your home. And so in many cases we think, well, it's only normal for me to want to go sleep in bed. Usually that's not the preferential spot for sleeping. And so in many cases you'll find a favorite chair or a couch that you're most comfortable in. And so I would tend to recommend, at least for the first couple of days, is to have a spot where you have a comfortable chair, a couch, an easy accessible place to go to the bathroom and potentially get to the kitchen, and sort of have that as an alternative to necessarily maybe going to your bedroom or going up and down some stairs. But you will be able to do stairs immediately after the surgery itself. In addition, you'd also want to think about your entrance and exit from the home itself. And that was one of the things that we never really thought about early in the process of just doing this class. And so entering the home after you come from your surgical date is important. So you should look at, how do I get in from the house? How many stairs are there? Is there a handrail? Because you will be using a walker when coming into the home. And so knowing what you will encounter when you get home, as far as getting into the house, once you get into the house, the layout of that is fairly well known and you've probably prepared for that well. Those first couple of steps in, whether you have a handrail or not, may be a little bit more challenging. And so knowing that ahead of time, we will have a physical therapist on site that will help walk you through that, which we'll talk about in a minute. One of the last things you want to think about prior to your surgical date is the car that you will come to and come back from the hospital or from the surgical center. That vehicle doesn't matter so much as far as the height of the vehicle. It's more based on how far back that front seat will go. After the surgery, you will be in a knee immobilizer, and that knee immobilizer, you'll have to swing in and out of the vehicle. So depending on how far back that front seat goes will determine potentially which car you choose. It's easier to know that car may not go, or that seat may not go back far enough, and change the vehicle that you decide to bring. If it doesn't matter, or the seat doesn't go back far enough with either of the vehicles, you can always slide into the back seat. And so knowing that ahead of time may decrease anxiety surrounding your return. So talking about, we've talked about medications, the prep that's done as far as trying to decrease infection prior to you even arriving to the surgery through the soaps, the nasal swab, and some of the basic preoperative tests. We've also talked about preparing your home. And the last thing prior to getting to the surgical center is, what do I bring with me? Well, we've talked about the two medications, your blood pressure medication, and if you have an inhaler, bringing that. You want to have easy on, easy off kind of clothing. So a loose fitting top, whether it be shorts or loose fitting pants. As far as equipment that you'll need to bring with you, I would recommend you bringing a walker and also a knee immobilizer. The walker and a knee immobilizer, if you do not possess those either can be obtained again through our durable medical equipment here at the office, or they can be obtained at the surgical center itself. Those things you want to bring to the surgical center on that day, along with just a comfortable pair of clothing, easy shoes to get in and get on and get off, And then that takes us to the point where we're talking about your arrival, especially at the surgical center. So when you arrive at the surgical center, it's located on Rochester Road, and the entrance point faces Rochester Road. You walk through those front doors and to the reception desk. They'll check you in, and at that point, you go from that reception desk to the preoperative area. And at that time, you'll talk to the anesthesiologist, the nursing staff that is involved in your care, and they'll walk you through sort of what to expect while there. One of the things that they'll talk about initially will be the type of anesthesia that's used. That will typically be a general or twilight type of anesthesia, which will make you sleepy. They'll also talk about regional or local nerve blocks. These blocks are meant to help with pain control after the surgery itself. These blocks are done under ultrasound guidance. For our hip patients, this is a one-time shot. And this shot is meant to last 24 hours after the surgery itself. Also done under ultrasound guidance. For our knee patients, this is a catheter that is located around either the femoral nerve or obturator nerve that drips a small amount of numbing medication on it. This catheter is placed in the preoperative area and will remain there for 2 to 3 days after the surgery itself. The catheter will be hooked up to a device that will be giving small amounts of numbing medication to that nerve, and it helps with pain control afterwards. The nurse and anesthesia group will walk you through the expectations as far as when that turns off and how it operates. But basically, whether you have the one-time shot or the catheter itself, you will need a knee immobilizer when up and moving. Because that nerve is sleepy, much like if you sleep on your arm and you wake up in the morning and it's a little bit numb, that knee or that leg, you can't totally trust while that nerve medication or that numbing medication is working. And so a knee immobilizer is needed to protect you and keep you safe so that you can trust that leg when walking on it. The knee immobilizer is not needed all the time. It's only needed when you are up and moving. So if you're going to be going to the bathroom or going to the kitchen, you'd want to have it on. But if you're watching TV or sitting in a chair, you can take it off and leave it off, or working with physical therapy. So they'll walk you through the type of block that's used. For our knee patients, I talked about that catheter that's left or that's inserted through that ultrasound, and that's there hooked up to a device. That device will let you know when it's done. And at that time, there's a clear plastic dressing that is sort of adhered to where that is inserted. You peel that off, and at that day, it gets removed. That knee immobilizer that we just talked about will stay on for 24 hours after the medication is stopped. So for our hip patients, if surgery was done on a Wednesday, you'd want to have the knee immobilizer on Thursday, but Friday it no longer is needed. For our knee patients, that catheter, if you had surgery on Wednesday, is typically going to work Wednesday, Thursday, and Friday. And so when you pull that catheter out on Friday evening, all day Saturday, you'd still want to have the knee immobilizer on, but by Sunday, you would no longer need it. And so that takes us up to the time where we're getting close to the surgical time. One of the last things that you'll get prior to that will be medications that you'll need after the surgery itself. And so we'll start with 3 medications that you'll use pretty much around the clock. One will be the blood thinner. That's an aspirin, 81 milligrams twice a day, unless you're on a blood thinner prior to the surgery, and then you'll just resume that medication as you normally would take it. The next medication that's used after the surgery itself is Mobic, which is an anti-inflammatory. That's once a day. And the last medication is Tylenol. That's used every 6 hours, and I would tell you to use that around the clock. In addition to those 3 prescriptions, you'll also get a prescription for Tramadol, which is used for light pain, and then Norco, which is used for heavier pain. You'll get prescriptions for that. You'll also get a prescription for Colace, which is a stool softener. As a result of either taking the tramadol or the Norco, you may encounter either loss of appetite, a little bit of nauseousness, or constipation. And the Colace is needed to try to help with the constipation aspect of it. And as long as you're on those pain medications, you want to continue to take the stool softener until you're no longer using them. It is common for most of our patients to use something for pain, whether it be Tylenol, Ultram, or Norco, for upwards of 6 weeks after the surgery itself, and many times used primarily at night. So after you get those medications, that'll be given to your family member who's there with you at the time of surgery. We take you into the OR. The time in the OR itself is usually about an hour in duration, and the surgical time is usually about 35 to 40 minutes in length. After the surgery is done, Dr. Kanapke will come out and talk to your family member that's with you and describe what was done and how you're doing. And then ultimately, at that point, we will take you back from the operating room, back to the same room that you started with in the preoperative area. What you'll notice differently is that you'll have either the knee immobilizer by you at your bedside, and for our hip patients, you will have a dressing that's over sort of the back pocket area of your hip. And there will be a clear bandage that is adhered to the skin. And that's it. That clear bandage, and this is true whether it's for our knee patients or for our hip patients, will remain for 1 week after the surgery itself. And you remove that bandage at that time, like you would a Band-Aid, and it can be left open to air. The incision, whether it's our hip or knee patients, would be glued unless the skin integrity isn't strong enough. And then sometimes we'll use staples. Those staples will come out typically in 2 weeks. You can shower almost the next day after the surgery itself. And for our hip patients, they'll talk to you about hip restrictions, which will be talked about not only with the physical therapist that's on site, but also during your recovery. And that's not bending past 9 degrees, not crossing the legs, and trying to keep things sort of above your waist and right in front of you. For our knee patients, you'll also have that knee immobilizer next to you on your bedside. You'll have an ACE wrap that goes from your ankle to your thigh, and then also that same clear bandage that's over top in the front part of the knee. Typically also that incision is glued, and that dressing also stays on for 1 week. At that time, when you're in the recovery area, the anesthesiologist and the CRNA will be monitoring your vital signs, making sure you're coming out from anesthesia comfortably, and then we get you up and get you moving with physical therapy. And Dustin will talk to you a little bit about what to expect during that time.
Thanks, Joel. So as he mentioned, I'm with Team Rehab. We've worked with Dr. Kanapke and his team for a number of years on this project and are very excited to be continuing that. Joel's mentioned in the talk a couple times, we have a physical therapist on site at the surgical center. After surgery and after you have kind of shaken the cobwebs out from the anesthesia, he'll come into your room and he does a number of things with you that day. But ultimately, it's preparing you to go home and to be alone at home for a day or two. So first thing will be adjusting that walker that you'll be utilizing. Make sure that it's fit appropriately. We'll teach you how to get in and out of bed, up and down from a chair, walk with that immobilizer in a safe fashion. One of the big things that he does, and a really important step in the process, is has you practice going up and down stairs. And as Joel mentioned earlier in the talk, some people have bedrooms upstairs, but most of us have at least a couple stairs leading into our homes, either through the garage or through the front door. And you'll need to be able to do that in a couple hours after this surgery. So he'll make sure that you're able to do that and you've done it and you're very confident in that. For the hip patients, he will continue to review those hip precautions that Joel has mentioned. Make sure you understand them, what you can and cannot do, should and should not do. He'll take all of the patients through a number of exercises. Those are designed to kind of wake those muscles back up and start the healing process, get them moving so that you are able to safely be on your feet and that you know what to do in your downtime, because you'll have plenty of that as you're recovering. And then depending on whether you're a hip or knee patient, you may have other interactions with us at Team Rehab. Some select patients will have a pre-operative home visit from one of our therapists to kind of go through some of the steps that Joel was talking about in the home inspection phase prior to surgery. And then some of you will have some home visits from our therapist after surgery. Usually it's only a session or two, but ultimately the goal is to get you into the clinics. And that's predominantly for the knee patients. After you have a session or two of physical therapy at home, we get you into the local Team Rehab location that's convenient to you. Usually it's the same therapist that came and saw you in your home, and you'll work with that person 3 times a week for whatever number of weeks that you need to get back on your feet and back to doing the things that you would like. But ultimately the goal is to make that happen as quickly as possible. They'll sit with you and establish your goals and try to figure out what was the reason you had the surgery. What can't you do? What did you not like the way that you were having to do? And what do you want to get back to doing on a regular basis in a pain-free environment and getting back to an active lifestyle? And they create that program to suit those needs in the quickest way possible. When you have started physical therapy in the outpatient setting, you won't be driving yet. And Team Rehab, as a company, we provide free transportation for patients in your situation. So we're happy to pick you up, bring you to your physical therapy visits, and then take you home afterwards. And we'll coordinate all that for you and take care of that as needed. I believe that's all I need to say, so I'm going to jump off and give it back to Joel here.
All right. Thank you, Dustin. So that gets us to the point where we're about ready to leave the surgical center and return home. Your total time at the surgical center will typically be about 4 to 5 hours in length. And you will want to remind the family member or significant other that's with you at the day of surgery that they will need to remain there the entire time. They can't go and grab some coffee and come on back. They'll need to be on site the entire time during the time that you're there. And so we get you at that point, the therapist has worked with you, they've gotten you up and down stairs, you're comfortable, you're stable, watching your blood pressure and vital signs, and then we get you home. That first evening, you find that comfortable couch, chair, or bed using ice about 30 minutes at a time with an hour break in between, and sort of using the pain medication that we outlined. And then we're getting you ready for the next few weeks. The following day, the home therapy will start, whether you're a hip or knee patient. And that home PT will typically be anywhere between 1 visit for many of our hip patients, and for some of our partial knee replacement patients, to upwards of maybe 5 to 6 visits. Really, it's to the point until you feel like and between you and the therapist, feel like you're ready to sort of do things on your own or get to an outpatient setting. Now, for our hip patients, there is no physical therapy that's needed, at least not early in this process, potentially not until about 6 weeks after the surgery itself. But for our knee patients, you will transition from home physical therapy to an outpatient setting. And again, Dustin outlined it, how long that may be. During the next 2 weeks is the hardest 2 weeks as far as what you will encounter. And there can be a lot of anxiety about what's normal and what's not. And so this next part of the talk is sort of to talk about these next 2 to 3 weeks and what you can expect, what may be normal and what may be abnormal. And we've listed these and we'll go through these. And with any of these sort of common symptoms, The underlying key is that whether we're talking about swelling, discoloration, warmth, or redness, if there is no increase of your pain level where you all of a sudden need more pain medication or what you've been using in the past is no longer working, many of these things will be normal, and we'll talk about that. But when we see a combination of swelling or warmth or a fever and increasing pain, that's definitely something that we would recommend either contacting us directly at the office, contacting either the orthopedic surgical center and letting them know, or using our patient portal. Those are the three preferred ways to communicate with us and ultimately to get resolution to your questions or concerns. So the first symptom is usually the swelling or discoloration. Now, it's expected. If you had a hip or knee replacement, you can expect the knee or the hip to be swollen. That wouldn't be a surprise. But many times you're going to have swelling of your foot, ankle, discoloration behind your knee, around your thigh, around your ankle, or even in between your toes. You can see that happening and usually peaking at about 2 to 3 weeks after the surgery itself. If it's just swelling and not having any increase of pain, nothing to be alarmed by. And the best thing to do is get off your feet, elevate, and use a little bit of ice. And so you will expect swelling even into the foot and ankle after the surgery itself. And it can be to the point where it can be hard to get normal shoes and socks on. The next thing that we typically will see is usually around the incision itself. So the incision can be warm to touch. That's normal. It's sort of indicative of having recent surgery. It doesn't mean anything good or bad. Also, sometimes you can see a little bit of redness around the incision itself. That also is somewhat normal. That's sort of blood underneath the skin and can be expected. When it comes to the incision, like we talked about briefly, you can shower on day 2 after the surgery itself, even with that dressing in place. And when that dressing comes off in a week afterwards, you can still shower as you would normally. We wouldn't recommend you getting into a bathtub or even into a swimming pool until about 6 weeks after the surgery itself. And we'll talk about that in a minute. Other things that you can expect surrounding the surgery is a little bit of an elevation of body temperature. Usually for the first, probably 4 to 5 days after the surgery itself, you may see a low-grade temperature, 99.8, 100.8, 100.1. Those things, after the surgery itself, you can see that for a few days afterwards, and nothing to be alarmed by. But if it is like 101 or 102, definitely something that should be brought to our attention. There will be some areas, especially around our knees, that you'll notice some numbness around the incision itself. Usually on the outside part of that incision, it can be and will be a little bit numb. That's just something that changes around skin level, gets better as weeks and months go on. But that's also something that you'll note around the incision itself. And so you'll see swelling and discoloration, warmth from the incision, potentially some redness, and also some mild elevation of body temperature. The last two things that we sort of talk about that are probably the most concerning is that you will, one, feel quite tired after the surgery itself. Your get up and go will sort of be gone. So you'll feel more fatigable with just simple things during the day. And that will last upwards of about 4 to 6 weeks after the surgery itself. And so every week that fatigue will lessen. But if we don't notify you that this is going to be an experience that you'll feel, it can be a little bit unsettling if it's a month out and you're still feeling like, man, my get up and go is just gone. I go to the store, I'm taking more frequent naps. But those things can be expected after joint replacement surgery, whether it's a total hip, a total knee, or a partial. Along with that is that you typically won't sleep well. And so usually your sleep is very broken or interrupted. It's sort of like with sleep, it's like if I told you after the surgery, let's say a couple of days or even a week out, get into a car and take an 8-hour drive. Don't get out. Well, you'll want to get out and stretch those legs about every 1 or 2 hours. And the same thing's true with sleep. It's not pain that typically stops you. It's restlessness. You just feel like you got to move, change positions. And so typically with sleep, for the first 6 to 8 weeks, you may feel like your sleep's fairly broken, where every hour, 2 or 3, you're having to move and change positions, use some ice or use a pain medication. And so those things you can expect, definitely the fatigue and the lack of sleep, for the first 4 to 6 to 8 weeks after the surgery itself would be expected. And usually when it comes to sleep, taking that pain pill, whether it be tramadol or Tylenol or Norco, prior to going to bed sometimes is helpful. And that's why we say many of our patients will use pain medication for about 4 to 6 weeks after the surgery itself. And so that gets us to the point where we exit out of 2 weeks and we start at that time usually re-expanding our world. At about 2 weeks, we'll see you back in the office for a visit, take x-rays, see how you're doing. Potentially, if you're a knee patient, get you started in outpatient physical therapy, which Dustin sort of touched on. And the outpatient therapy will last usually about a month from there. And so usually around 6 weeks, 6 to 8 weeks is where that sort of wraps up based on your goals. Our expectation at 2 weeks is that, again, you start re-expanding your world. You can think about driving, usually about a week or 2 weeks after the surgery itself. And these are some milestones that are outlined here on this slide. Showering again at 2 weeks, returning to driving, usually around 1 to 2 weeks, although sometimes it can be a little bit longer. You're usually going to get rid of the walker at about 2 weeks and start using a cane. At 2 weeks, you can start going to the store, going out to eat, making some small trips. And during that first from 2 weeks to 4 weeks is a time to get your legs back underneath you and start to reclaim your normal day-to-day routine. We will then again see you in the office at about 4 to 6 weeks after the surgery itself to see how you're doing. And at that 6-week visit is a time where for our hip patients, the hip restrictions go away. And for both our hip and knee patients, you start contemplating, what are the things that I want to do? Am I a walker? Do I like to go to a certain class or do certain exercises? Do I want to get onto a bike? You start to establish a routine. Usually at 6 to 8 weeks, the statement that's true is that I can do most things that I want to do, but I do none of them well. And so there's still the lack of endurance, there's still the lack of strength that needs to be worked on. But establishing a routine of exercise at that time, at 6 to 8 weeks, is critical so that we start building back our stamina and strength. Things like going up and down stairs one after another typically takes about 3 months. Long term, there are no long-term limitations or restrictions. And so you can kneel, going up and down stairs, walking any distance that you like, running down a base path, downhill skiing. Those things are expected, but typically take at least 6 months before you'll do all of those things well. Between that 6-week visit until 6 months is a time to sort of get back, sort of coordination, strength, balance, and those things will improve as time goes on. And it really is dependent upon establishing that routine and sticking with it. And so again, our expectation is that it's a painless knee that lets you do anything that you want to do. Now, again, going back to those visits, we'll see at that 2-week visit, and then usually around 6 weeks post-operatively. And then depending on how you're doing, either seeing you one more time as you're recovering, usually like 3 to 6 months out, or if things are going very smoothly, at about a year after the surgery itself. And then after that year anniversary, about every 5 to 7 years for new x-rays and see how you're doing. One of the things that we taught that has continued to change is antibiotic prophylaxis prior to dental work or cleanings or some procedures. At this time, we only recommend that during 3 months after the surgery itself, that you avoid any dental work, cleanings if at all possible. If there are things that are emergencies or needing to be done, then and only then during those 3 months that you'll need an antibiotic prior to those procedures. But again, long-term, no long-term antibiotic would be needed. So we will have a class or at least a meeting time over the next several weeks to go over any questions or concerns that you have after viewing this video. You will receive an email notification of the timing of that class, and it'll be a time that we can answer any outstanding questions that you may have prior to the surgery itself. I definitely appreciate your time and look forward to our discussion on the Zoom call. And if you ever have any questions, like I said, either using our patient portal, contacting us at the office by phone, or contacting the Outpatient Surgical Center in Rochester are your 3 best modes of communication. And we look forward to seeing you. Have a great day. Bye.